Good evening, everyone. Good evening, attendees. Welcome. This is Dr. Amal Al-Muhawis. I am honored to moderate this session today. Welcome, everyone, to our combined International League Against Epilepsy, Eastern Mediterranean and African Combined Epilepsy Educational Webinars. Our topic today is about EEG and brain death, which will be presented by our speaker, Dr. Sundus Al-Hindi. Dr. Al-Hindi obtained her medical degree from University of Dammam, then completed adult neurology residency at Dalhousie University in Canada. This was followed by two-year fellowship in EEG and epilepsy at McGill University in Canada. She is currently an adult neurologist, clinical neurophysiologist, and epileptologist at Johns Hopkins Aramco Healthcare in Dhahran, Saudi Arabia. Please, Dr. Hindi, the mic is yours.
Good evening, assalamu alaikum, everybody. Thank you for attending and thank you for inviting me for this webinar. I hope it would be useful and entertaining at the same time. Maybe not that much entertaining. Anyways, I'm going to share my screen. Hold on. Let's see. All right. And is my screen available now for everyone?
Yes, you can go ahead, please, Dr.
All right. All right. So we've got plenty of time of discussion of cases, and we're, I think, in topics like these, different experiences and case discussions are the most important. So my topic is going to be, of course, I was asked to talk about EEG and brain death. Hold on, this is not. All right, we'll do this like that. Okay. So roughly the outline of this talk would be trying to first, of course, I always start with definitions. To be clear, what brain death is, the definition of an ancillary test. What do we mean by ancillary tests in trying to define brain death? And then we'll talk about EEG again. I know most of the attendees over here are probably neurologists or somebody who knows somewhat about neurophysiology. However, there might be some junior learners who might not know exactly what EEG is and how that limits us or helps us. So we'll try to further define EEG and talk about its limitation. And again, talk about the use of EEG in brain death. So to start with history, the first concept of brain death emerged back in the 1950s. And then this was later modified, or we've tried to put it in a formal definition back in 1968 by the Harvard criteria. But this criteria was not full-blown, and it was only used at Harvard University and medical centers, but started gradually pertain some positive feedback. And then the Uniform Determination of Death Act clearly defined brain death back in 1981. So from 1968 until 81, people were scrutinizing the criteria, looking into the positive of it, but it was not a universal definition. It was not broadly used, especially in North America either. Later, in 1995, the American Academy of Neurology published evidence-based practice parameters of how to identify somebody as brain death based on the Determination of Death Act definition. These parameters were updated back in 2010 due to increase of use of hypothermia in patients with cardiac arrest and other modalities of resuscitation and preserving brain function like ECMO and so forth. And most recently, in 2020, there was the most recent article that was published was Determination of Brain Death or Death by Neurological Criteria, the World Brain Death Project Criteria. This is the most recent publication, and it's not too different from the previous criteria by AN. They just further looked into the criteria of apnea testing and ancillary testing and tried to universalize the brain death project. So if we go back to definition, let's start by the most, the oldest definition, that is the most used definition now. So what's the UDA Act, the Uniform Determination of Death Act? It says that an individual who has sustained either an irreversible cessation of circulatory and respiratory function is dead, or who has sustained an irreversible cessation of all functions of the entire brain, including the brain death. So either you have a clear-cut cardiopulmonary arrest, then you can say that the patient is dead, or somebody who has a clear-cut loss of all brain function, then they're dead. You could have one or both. Again, back in 1980, they said the determination of death must be made with acceptable medical standard, whatever standard was at that point. And again, now in future, applying the same criteria on our current standards and knowledge. Later, as I said, the AAN practice parameters said that it does not recommend any ancillary test beyond a single bedside neurological examination and an apnea test to determine somebody as brain deaf. The only time where you need another test to support your clinical assessment was in two cases: if you're unable to complete an examination, or your examination is not reliable for any reason, or the results were equivocal. You're not sure if was there a sluggish reaction, a very mild reflex or not. So let's talk about the published most recent criteria, the World Brain Death Project. Again, it's a long article, but it's a very beautiful and easy to read article. It's very nice for anybody in neurology or ICU. It was first published in Critical Care and JAMA, and it goes through each and every criteria. So what's their concept of brain death, or what they've defined as death by neurological criteria? It is defined as a complete and permanent loss of brain function, as defined by an unresponsive coma with loss of capacity for consciousness, brainstem reflexes, and the ability to breathe independently. They also said that persistence of cellular level neuronal or neuroendocrine activity does not preclude the determination, meaning that let's say you've got a few, as we mentioned, when we say cellular level neuronal activity, meaning a very mild, let's say, EEG activity by itself, when you have a clear-cut clinical diagnosis, does not mean that the patient is not brain dead, or does not interfere with your definition. They also said, let's say you did neuronal ILAE levels, or you did other hormonal, not hormonal, I would say, enzyme levels, and they were not clear cut, but clinically, patient is in coma, unresponsive, does not have brainstem reflexes, and cannot breathe independently. This does not preclude that the patient does not have, by definition, brain death or death by neurological criteria. And when we talk about complete and permanent, meaning that there is no way that these functions are going to resume either spontaneously or by a medical intervention. So to them, they said the minimum clinical criteria for determination of brain death or death by neurological criteria would be first to determine, establish that the clinical history of this patient's etiology and neuroimaging demonstrate that the patient has experienced an irreversible, devastating brain injury leading to loss of all brain function. So here it's very important, of course, when you get the clinical history. Let's say somebody had a cardiopulmonary arrest. How long were they down? How long they receive a CPR? How long was it until they receive a CPR? How long it took to resume circulation? All of these things, of course, adds to your predictive value. There's no confounders that could make the person appear to have irreversible brain injury when in fact this is not the case. We'll talk about what we mean by confounder. Confounders means that something that would make a person in coma, for example, a medication-induced coma or medical coma, secondary to sedatives, or deep sedation secondary to, let's say, barbiturates, propofol, and so forth, or a severe metabolic derangement which would affect your clinical assessment. So again, there are basically 3 steps for you to confirm a patient has a brain death or is dead technically. First, confirm the patient is in coma by knowing your history, absence of confounding factor. Then confirm the absence of brainstem reflexes. After all brainstem reflexes, some people skip a few. So you should not skip any brainstem reflexes, including the caloric test, right? gag reflex. People sometimes do the gag reflex. Sometimes people skip it if the patient is intubated, or just rely on moving the tube. Sometimes you do deep suctioning to make sure that you don't have any reflex gone. Most often people don't do is the caloric test. Once you've confirmed that there are absence of all brainstem reflexes on a clinical assessment, then you do the apnea test. We never perform the apnea test without a clinical baseline assessment of a brainstem reflex, because if you don't have absence of brainstem reflexes and you do an apnea test, that is added distress to the patient. You should never perform an apnea test when you have any question about your brainstem reflex examination. If the apnea test shows no spontaneous breathing, then the patient is brain deaf, according over here. If there was any abnormalities or the test was aborted for any reason, either you repeat the test or you do an ancillary test to confirm the brain death. So again, what are the reasons for us to perform to not be able to clinically diagnose a patient to be brain deaf? And a reason for us to perform an ancillary test would be inability to perform a complete examination. For example, a patient who has residual sedative effect, has severe metabolic derangement, which you cannot correct, or it's out of your control. And we'll talk about a few cases or examples for that. Patient has cervical, spinal cord, or peripheral nervous system injuries secondary to trauma, or a previous underlying peripheral neuropathy that could affect your ability to perform the examination. Facial injuries with inability to examine all cranial nerves, and most importantly, posterior fossa mass or lesion. Reasons for inability to complete or abort an apnea test would be patient has underlying hypoxia, or is known to have, let's say, severe lung disease with underlying hypercapnia, hemodynamic instability, cardiopulmonary bypass, patient with a baseline hypercapnia due to chronic lung disease. All right. So when we talk about ancillary tests, what do we mean by ancillary tests? We say ancillary tests, any test that you would do to support your clinical diagnosis or clinical suspicion that this patient is brain dead. They're basically divided into two major groups: tests of cerebral perfusion, right, which would include CT angiography and perfusion, or MR angiography and perfusion, transcranial Doppler, nuclear medicine scan looking for any perfusion, most often used SPECT. And other tests would be neurophysiological tests, EEG, which is our main topic right now, and somatosensory evoked potentials. So looking into EEG, right, when there was an article published in JAMA back in 2012, which looked into the variability of brain death policies in the United States. Of all the responding hospitals within the States, and we're talking about North America and the States, when we looked at the different ancillary tests, the most commonly used ancillary test by different physicians at different levels of, you could say, hospitals, primary, tertiary, secondary care hospitals, EEG was listed as the most commonly used test, followed by catheter angio or nuclear perfusion scan. Again, similar numbers were found worldwide. So published back in 2015, Brain Death Declaration, Practices and Perceptions Worldwide. It was founded that ancillary tests was mandatory in about 1/3 of all the countries that participated, and a lot of countries participated in North America, Africa, Asia, Middle East. And so 28% of the countries reported mandatory tests, EEG being as a mandatory test for them to declare brain death. An additional 47% included EEG as an optional test. So again, EEG got a quite high number of percentage of or one of the top ancillary tests, you could say, that people have used worldwide to support or confirm brain death. So again, they looked into the same thing in a different way. In 2021, in Neurocritical Care, there was this article which looked into ancillary testing for determination of brain death. What they tried to really look was what were the practice parameters that each test in different countries required, or did they have a clear guidelines that would help uniform the use of these tests and its findings. And they made a diagram in each ancillary test, and we're talking about EEG. So it's interesting. They had an N of 56 people who contributed or used EEG as part of their ancillary test for brain death. And when they scrutinized each EEG and their requirement, there were a lot of variability in terms of what the different countries required in terms of techniques, interpretation. There was quite a significant variability. However, did they report maximum amplitude, or they just reported isoelectrical activity technique? What were the number of electrodes that each country or each hospital specified? Some countries really had clear-cut guidelines. Some countries followed the American ACNS guidelines, the American Clinical Neurophysiology Guidelines. Some countries had their own guidelines, like in France, like in Korea, they have their own guidelines. Some countries didn't really have a clear-cut guidelines for brain death or EEG and brain death. So there was quite a significant variability in technique. Some people said it's okay to have a 10-minute recording. Other people said 20 minutes of recording is mandatory. Others required a 30-minute recording. The majority was 30-minute based on the guidelines that have been published, let's say by the ACNS or the Korean guidelines or the French guidelines and so forth. And then people who were really able to identify the limitations during their recording, let's say they were limited by sedatives, by hypothermia, by other factors, and people who had nothing to specify or no clear, let's say, guideline of what EEG should be. So due to this variability, it's interesting that the most recent project, the World Brain Death Project, suggested that EEG no longer be used routinely as ancillary tests in adults. I mean, they already said that you don't really need it to clinically diagnose brain death, but they really are kind of pushing to be away from EEG. To them, it's probably better to use a perfusion study over EEG due to its limitation and confounding factors, and we're going to talk about this further on. So when and how to use EEG, you would use it if it was mandated by your regional law and policy. You would use it, and for you to use it, they recommended to use EEG in conjunction of a somatosensory and brainstem auditory evoked potentials, given the limitation of EEG for evaluating a brainstem function. So for those of you who don't know what is somatosensory evoked potential or how it's performed, it's basically, it's an evoked potential and it's somatosensory. So it looks at the whole pathway. You need to you're looking at the peripheral nervous system, the plexus, the brainstem, up to the cortex. Basically, you're going to be, let's say, recording from the median nerve, just like you'd be recording recording from the APB for the median nerve, stimulating at the wrist, at the elbow, stimulating at the Erb's point, and then recording all the way up and looking for a response at the cortex. That's an evoked potential. You're going to look at the potential of the cortex, and you're going to be recording it from the both sides. Now, this ancillary test really looks at the whole axis of the nervous system, muscle, peripheral nerve, brainstem, and so forth. And it's not confounded by medications, but it has its own limitations. Let's say somebody has peripheral neuropathy, you won't be able to perform it. So because one test has its limitation, the other doesn't have it, doing a combined ancillary test would increase your sensitivity, especially if you're looking to neurophysiological tests. And that's why a lot of people perform one neurophysiological ancillary test along with, let's say, a perfusion study. And again, when you use it, you have to really be caution about how you're using the EEG. You should use it according to the guidelines of the EEG and interpret it according to your regional guidelines. If you don't have regional guidelines, try to follow one of the international public guidelines, published guidelines like the ACNS guidelines. So one of the most strongly used guidelines are the American Clinical Neurophysiology Society guidelines, which was first published in terms of brain death minimum technical requirements back in 1970s. At that point, they said that non-physiological terms such as electrocerebral silence, isoelectric, linear, and flat were replaced by electrocerebral inactivity, which was more accurate in terms of describing what we're dealing with, and I would say more professional than just saying it's a flat EEG. All right, so what did these guidelines, or what were the minimal technical standards? This guideline is also, as I said, very easy to go through and very easy to read. And it really has 11 criteria. I'm not going to go through each and every one. Some of them are very technical, but there are a few points that we need to talk about. Overall, what they defined as electrocerebral inactivity is the absence of any artifactual EEG activity over 2 microvolts when recording from a scalp electrode pairs 10 or more centimeters apart with inter-electrode impedance between 100 and 10,000 ohms. So a few key points about these guidelines. So a complete complement scalp, what they mentioned, what we should do in the, when we're recording EEG in a case of brain death or suspicion of brain death or for brain death. So your tech would go and you will tell them, listen, I've got an EEG for you and it's possible brain death, or this is to rule or conform to, assess and diagnose a brain death. Sometimes you know that ahead of time and sometimes you don't. So regardless of that, the tech would put a complete set of electrodes, the International 1020 electrodes, and there are more than 8 electrodes that are part of the guidelines. And when you're placing those electrodes, according to the 1020 international system, the distance between each electrode is about 6 centimeters, right? So, but what we need is about 10 centimeters difference. So why are we placing a complete set? We are placing a complete set of electrodes, or we're not really skipping it while placing electrodes, because we want to make sure that we're covering all major areas of the brain, right? And that we're not seeing just a regional phenomena of absence of brain activity. And when we're having somebody with a EEG that is suspected with isoelectrical activity, isoelectrical stability activity, it may demonstrate other abnormality. As I said, sometimes you go in with that pre-notion that this is brain death. Sometimes you don't know. And a lot of times you'd be surprised thinking that this is brain death, but you find other abnormalities or other activities. So for you to be able to diagnose other conditions, you should be having a full set of electrodes. Now, when we put a full set of electrodes, then we can play with the montage and do a brain death montage after that. So this is a full set of electrode, the 1020 international system. The montage for the brain death or electrocerebral activity should, as I said, have at least 10 centimeters apart. So when we're doing it, usually we have these 1020 electrodes. They're about 6 to 6.5 centimeters apart. But when we're doing the brain death montage, we skip one electrode. So you're going to see a montage rather than having FP1, F7, F7T3, you're going to have FP1T3. Rather than having a parasagittal FP1, F3, you're going to have FP1, C3, C3 to O1. So you're going to basically be having double distances. All right. Again, when we usually do a bipolar montage, and we do a referential montage, right? For bipolar montage is what I explained. For referential montage, often we avoid any auricular or ear references due to its high contamination with EKG, and we try to get a very midline vertex reference like CZ. All right, this is what I would call a textbook example of brain death recording, where you have double distance montage. The sensitivity is at 2 microvolt, and you are not able to see any underlying cerebral activity. This is electrocerebral inactivity, basically what was defined previously as a flat EEG. All we're seeing is an EKG artifact. All right. So what are the other settings that we should be aware of? The sensitivity must be increased to a maximum of 2 microvolts. And why is that? Because you don't want to miss out any low voltage, slow activity. Now, low voltage could occur if you have, let's say somebody has a bleed, has a cortical mass or an infarct that's preventing your structural recording, and you don't want that to affect an underlying subcortical activity. All right, the recording must be for at least 30 minutes. There have been some reports of having spontaneous activity after 20 minutes of recording, and to avoid those case reports and those kind of instances, especially when you're trying to declare somebody as a brain death, the minimum criteria is to at least 30 minutes recording or more. Okay, what about filter setting? Again, it's very important to have a clear-cut filter setting when you're reading your EEG and recording it. The low voltage, to avoid any attenuation, again, low voltage, fast or slow activity. The high frequency filter should be set, should not be set below 30 hertz, and the low frequency should not be above 1 hertz. While recording, your tech would be there and stimulating. If not the tech, you as a physician might be there either examining, stimulating, seeing the EEG at the same time, and you should be able to not have any EEG reactivity. There should be no EEG reactivity to any intense somatosensory, auditory, or visual stimuli. What do we mean by EEG reactivity? Again, definitions are very important. EEG reactivity means a change in your EEG frequency, EEG recording, or the waveline frequency, amplitude, or a spread, right? So mainly frequency and amplitude. If you see any change, let's say there was a flood, or let's say a low voltage activity, and then you start seeing a theta frequency coming on, and a change in amplitude becomes high voltage and so on, that's an EEG reactivity. And it should be a persistent change. It wouldn't be for 1 second. It would be a good, there are different definitions to EEG reactivity. Some people say about 6 seconds. Some people say about at least a good 10 seconds. A change in EEG frequency or amplitude, that would be an appropriate reactivity. But even let's say an EEG reactivity of 3 or 4 seconds, when you're trying in a critical case declaring brain death, you have to be very cautious. There should be no EEG reactivity whatsoever. Again, so in summary, what was the criteria by the American Clinical Neurophysiology Society? An isoelectric EEG brain death requirement would be minimum of 8 scalp electrodes, impedance between 100 and 10,000 ohms, inter-electrode distance of at least 10 centimeters, sensitivity of less than 2 microvolts, time constant of 0.3 to 0.4 seconds, high frequency filter of more than 30, low frequency filter less than 1, recording of more than 30 minutes, and testing of EEG reactivity is very important. So this example of EEG that is for brain death, but if you notice, the sensitivity setting's at 7. And when you look at this EEG, you would say, oh, this is a flat EEG, it's brain death. But reporting your EEG at that sensitivity is wrong, and you could falsely declare somebody as having an isoelectric superactivity. We change look at the same page with appropriate setting, you're going to say, again, there's not a clear, what we would call the underlying cerebral activity. These low voltage waves that are coming, it's very doubtable. This, of course, in the middle is an artifact. Keep in your mind, these are most of the time ICU settings recording. And so these artifacts are very common, but there's really no clear underlying cerebral activity that you could see. All right. So now that we've talked about the EEG, we talked about the definition of brain death. We talked about when to use the ancillary tests. And we talked about the minimal criteria of EEG recording. Let's talk about the EEG itself. Some people might say, okay, we've got all these technical standards, but again, earlier on, Dr. El-Hindi, you said that, there's been a recommendation not to use EEG. And why is that? So EEG is a test of cortical function, especially when we're talking about scalp recording. When we're recording in the scalp, the brain itself has basically the cortex, which is the gray matter, and the subcortical structures with the white matter, and the basal ganglia, the deep structures. The surface electrode really is looking at the summation of the excitatory and inhibitory postsynaptic potential occurring at the cortex, at the apical dendrites, right over here. You're recording from here, but you're really looking at these neurons. So if you have a very deep structural damage, right, you might see some EEG changes, right? But that deep structural damage doesn't mean that the patient can wake up or is alive or can have a normal or any form of sustained life. And if, let's say, you have what we call just a cortical damage, you might get a flat EEG, but the rest of the functions, subcortical structures are working fine. So this is what we call about its limitation. And it's really just looking at the cortex and not giving you a clear-cut indication about the subcortical structures. So the advantages of doing an EEG overall. It may help determining the class or the general category of a disease process. So you could say the patient is in a form of coma, and you have different types of coma. You could say the patient is in a spindle coma, alpha coma. You could say the patient just basically shows non-specific slowing. It's a form of encephalopathy. So it can help you that. You could say patients having periodic discharges, a form of a category of a disease. It can be very useful in determining the prognosis in some conditions. So let's say, you're not seeing a clear-cut brain death criteria, but let's say this is a case of a patient post cardiac arrest, and you're seeing clear-cut status myoclonic. You know that that's a very poor prognosis of recovery. And of course, why do people use it? If, as I mentioned earlier, it's one of the most common tests used worldwide because it's safe, it's inexpensive, and it's readily available in most hospitals. Even in a small community hospital, you will find one portable EEG machine easily. However, you might not have an availability of a SPECT or a nuclear medicine scan. You might not have a 4-vessel angio available in a small community hospital. So that's probably why people use it most often. One of the disadvantages is that, again, EEG is highly susceptible to sedative medication, hypothermia, severe metabolic derangement. And so the current AN guideline recommends a waiting for at least 5 elimination half-lives of sedative medication if the time of drug exposure is known, or measuring plasma levels before doing your neurological examination or doing your EEG recording. I guess most of us, probably, know this. We get a call from ICU, but we can't get an EEG because the patient is on sedation, on propofol. We have to wait. Sometimes we're able to get the sedation off, but they're still, they have a low dose midazolam going on, some fentanyl to keep the patient calm so that he doesn't pull the tube. You've got so many confounding factors. So you have to be very cautious about these things and get a detailed information of what the patient is on during the recording and when was it stopped. All right. Other limitation of the EEG, I've already mentioned this part. The most important issue with EEG is understanding that it's a measurement of a cortical function, and subcortical structures are not necessarily well assessed. The cerebral cortex is relatively vulnerable to ischemia. That's a very important thing too. So one of the, cardiopulmonary arrest, but the patient gets resuscitation, there's resume of circulation, but now the patient is ventilated and we don't know if they're going to recover, or we don't know if they've got brain death. Issue with ischemia or hypoxia, there are certain areas of the brain that are very vulnerable to hypoxia. And one of the most vulnerable areas are actually the pyramidal cortical neurons, right? And the most resistant to hypoxia is the brainstem. So the patient might have what we call a cortical necrosis. And unfortunately, I don't have a beautiful image. I maybe could have Googled it or so on, but you can do an MRI, and on diffusion weighted, you're going to see what we call a cortical ribbing, a bright line just around the whole cortex, indicating that there's ischemia just to the pyramidal neuron or to the cortex, and it could makes that ribbing line. You could see that in other cases apart from hypoxia, in some cases like in CJD and other infectious cases. But most constantly, that cortical ribbing tells you that the cortex is damaged. There are other areas that are more like, let's say, the hippocampus is prone to hypoxia, but the brainstem is the most resistant. And so your patient could present with a flat EEG because of that cortical ribbing, but you do a clinical assessment and the brainstem reflexes are present. So clinically, they're not brain dead. Again, accordingly, isoelectrical activity has been described among patients in a persistent vegetative state. This is exactly what I've been trying to explain, that you could be having somebody with a complete cortical damage. They would be in a state of coma, and they would be in a persistent vegetative state because of their subcortical structures are still functioning, but that doesn't mean that they're going to have a full recovery. Yet again, it doesn't mean that they're brain dead either. So having a flat EEG doesn't always mean that the patient is brain dead. All right, technical issues in EEG recording. It's usually done in the ICU often contaminated by artifact arising from the monitor, equipment, life support, personal. I've recently talked also a phenomena, but we've already declared that it should not be any EEG reactivity. A phenomenon seen in ICU recording EEGs called serpents. You will see an ecto-like discharge or reactivity just because of ongoing external stimuli. It's rare, but the whole setup gives a lot of contamination to our EEG. Again, EEG is vulnerable to most of the confounders to physical examination. So just like you can't do a clear-cut clinical examination because the patient on sedative medication, you can't get a clear EEG. So in summary, EEG has a long history as a confirmatory test in brain death. Recent studies demonstrate that when clinical assessment of brain death is performed in accordance to accepted guidelines, then the EEG findings are only rarely discrepant. Patient with posterior fossa lesion may be an exception. Again, posterior fossa lesions are going to limit your examination, your ability to perform an apnea test. Posterior fossa lesion can also on EEG show you different forms of coma. These comas would have a very poor prognosis, but would not be an isoelectrical inactivity, just like spindle coma because of the reticular activating system. Alpha coma, these have very poor prognosis. However, on EEG criteria, you cannot say that they're brain dead. And in some countries, EEG still remains a mandatory test for declaration of brain death. All right, I'm going to stop over here for any questions before we go on to cases. Is there any questions? Dr. Jumana, Dr. Ahmed?
I think, Dr. Sindus, we can continue with the cases.
Okay.
Then we'll answer all the questions together. Thank you.
Okay. So these are real cases that actually just came in the past month, I would say, past 3 weeks at my facility. And we're going to discuss which one of them are truly brain dead, which one are not, and what were the underlying situations. So this was an 82-year-old gentleman who was transferred to the ICU after suffering a cardiac arrest and prolonged resuscitation prior to return of spontaneous circulation. CPR was done for about 55 minutes, 30 minutes in a hotel. He was actually in a different, in Bahrain. For those of you who are from the region, they know it's very close by to Saudi Arabia. And so he was in a hotel. CPR initially was started for 30 minutes and then 25 minutes by the time the ambulance arrived, and then they took him to the hospital over there. He was initially at a different hospital and then transferred to our facility. So this was, of course, his examination was a clear-cut for brain death in terms of clinical criteria. He had absence of all brainstem reflexes, and we just before the apnea test, we had performed the EEG. So this is a snapshot of his EEG. Again, you would say this is a flat EEG. I could see some cardiac artifact, but again, be wary. We're looking at a 7 microvolt in terms of sensitivity. So changing it to 2, it goes on. You will see some, underlying low frequency or low amplitude frequencies, but this is not a clear-cut underlying either alpha activity, theta activity, delta waves. You're not able to see any waves. It's just a flat line with some EKG artifact. To further increase your sensitivity, you would further reduce your sensitivity to 1. When you do that, you're increasing your positivity of the test by about 50 to 100% if you further reduce your sensitivity. And further reducing it, that's what your EEG looks like. Again, what you're just seeing is an attenuation of underlying, other possible activity, but there's no clear-cut brain activity or cerebral activity apart from EKG artifact. All right. 58-year-old male, non-diabetic, hypertensive, uncontrolled hypertension with end-stage renal disease on hemodialysis 3 times a week, presented with acute confusion. He was intubated and sedated in the emergency department because of severe agitation. His initial CT had showed an acute interventricular hemorrhage from the inferior vermis of the cerebellum with extension to the 4th ventricle. So that's his initial. I just have one cut. I can't go. I didn't bring all the cuts for his CT, but that's his initial one. All right, forget about this one. That's his initial CT. It's just right over at the fourth ventricle, but luckily it didn't cause any hydro at that point. This is the reason of severe agitation, right? But if you look at it, it's very close to the brainstem. It's right at it's in the posterior fossa. Patient can herniate, can obstruct, so at risk of dying at any point, right? So but the patient, was sedated and his blood pressure was controlled, or he was put down. The thing is that he had severe metabolic derangement. His electrolytes were completely abnormal. Potassium was elevated. He's known to be on hemodialysis. So all of his metabolic workup was abnormal, right? I came in to assess this patient on day 1. I couldn't assess him because he was sedated. I came in to assess him at about day 3 and 4, where we were able to wean him off gradually of propofol. He became a bit agitated, but we had to give him a bit of a fentanyl. That's off propofol with fentanyl. We got this EEG. So in this EEG, before going to the EEG, off propofol and just on a small dose of fentanyl, just it wasn't really, to be honest, wasn't an agitation. I mean, there was some biting on the tube, but the patient wasn't really moving much, and his blood pressure kept spiking up. There wasn't any abnormality or movement. So off propofol on fentanyl, the clinical examination at that point was really absent brainstem reflexes and no motor response. He was a GCS technically 3 to me with absent brainstem reflexes, nothing. However, this was his EEG, right? So is he brain dead? Is this just a confounding EEG? Because my clinical assessment showed absent brainstem reflexes? I would say no. My clinical assessment, despite the fact that I did it on propofol, off propofol, he was not even a full 5 half-lives off propofol, and he was on low dose of fentanyl. And on top of that, he was getting hemodialysis. So the metabolic derangement, the underlying structural problem, would not be enough for me to assess fully and say that my assessment was clearly absence of all brainstem reflexes. Again, the EEG was showing what we say, there is a bit of an attenuation, there's a diffuse slowing, frontal predominant, is encephalopathic. This EEG, as I said, was done a few days after his admission, and he was not waking up despite weaning off sedation. So a repeat, I'm going to go back this way. A repeat imaging of the CT showed that he had actually, apart from the bleed that he initially had in the posterior fossa, infarcted extensively his MCAs bilaterally. He had subcortical infarcts. Now, this was a case of discussion why he had developed that, but this was a complication. And with all that, later on, we still had a lot of confounding issues, but after hemodialysis and other metabolic derangements, that had gradually improved, despite all these findings on his CT scan, the patient never woke up. He's probably in a persistent vegetative state. But clinically, again, waiting on him and repeating examination after removing all the confounding factors that we were able to do in terms of metabolic derangement, he was able to breathe on his own, so with pressure support on ventilation, and he ended up preserving his gag reflex with the deep suction in the tube, and he had very sluggish corneal reflexes. So he was not brain dead. But if this criteria was applied, or the clinical criteria was applied on the first assessment, then we would say, he's brain dead, but that's not accurate. All right, another case. This was a 34-year-old male, status post-cardiac arrest for about 28 minutes of resuscitation before return of spontaneous circulation. During his stay in the hospital, he was found to have severe anoxic brain injury, and he was on multiple anti-seizure medication, namely Keppra, Epival, or Dipykine over here, lacosamide. He was noted to have some myoclonic movements in his leg, but no clear seizures or continuous rhythmic movements. So when we say he was found to have severe anoxic brain injury, this was basically based on CT. They saw diffuse edema and some loss of gray-white differentiation, especially in the subcortical region, indicating that this is probably a diffuse axonal injury. So this was his EEG. And this EEG, again, some of the underlying, so it's an appropriate setting. The montage is not a brain death montage. However, if you look at it, we're not seeing slow wave activity. These abnormalities that you're seeing are electrode artifacts, right? Which are secondary to some movement, some positioning. This is just a pop, electrode pop, probably, but, and it wasn't, other pages, some of the pages had it, some of the artifacts were continuous, so I couldn't find a beautiful epoch. However, again, this patient has an isoelectric EEG. And if I put it on a brain death montage, it would fulfill the criteria for it. But the patient on clinical examination was not completely fulfilling the criteria. He had some sluggish reaction. A repeat examination a few days later, he fulfilled the criteria and was declared brain dead. And the issue was this with this patient is having, again, what we talked about, having a cardiac arrest and a severe anoxia, right? So we couldn't get an MRI on him, but he probably had cortical infarct or necrosis due to severe hypoxia and a prolonged resuscitation. Of course, why did this 34-year-old gentleman had a cardiac arrest was a different story. All right. I think I am. So for this case, I forgot to, did I? No. All right. So again, this is another case. 25-year-old male, previously healthy, was noted to have a prolonged tonic-clonic seizure at his place of work, and he was offshore. He was brought to the hospital through evacuation by a helicopter. The seizure apparently was supported by the paramedics with midazolam. However, and he was intubated. However, it was his GCS dropped to 3 right away. And when he arrived, he had complete fixed dilated pupil with no brainstem reflexes. This is a very unfortunate young man. He had bled extensively. He had a sudden severe headache, and it was found that he had a severe massive intraparenchymal hemorrhage with extension interventrically and herniation of the brain. So this is the one for some reason his EEG epoch is not here, but he had the most unfortunate, beautiful EEG of brain death in terms of montage, and literally a flat EEG, I would say, by terminology or description. No underlying small, what you would think would be, is this a beta activity ongoing, even with increased sensitivity? It's unfortunate this patient died and was declared brain death and died. So these are a few cases, which some of them could be clear cut on examination and EEG. Some of them have confounding factors. Some cases I presented just for a discussion of when to properly examine and assess and not to hurry in declaring anybody brain dead. All right, that's all that I have.
Thank you, Dr. Hindi, for this, as usual, informative, comprehensive talk. Please, attendees, if you have any questions for Dr. Hindi, to place it in the Q&A section. I can start with the first question. You talked about limitations of EEGs, and there was a question about that EEG is subject to many errors in interpretation, some involving physiologic that you have talked about. What about non-physiologic variables? How to avoid it, or what is it? So
You mean the non-physiological, you mean the external artifacts?
This was the question. I'm not sure.
Yeah.
Sure
So
about the
we try. I mean, the techs try as much as possible to avoid all the external artifacts. The impedance that I talked about, checking the impedance, checking all these variabilities are very important. A good tech needs to know all these things. I didn't talk about checking for impedance, checking for connectivity issues, checking for 60 hertz artifact. These are non-physiological variables that would affect your EEG. Physiological ones, apart from your heart and medication, of course. As I said, sometimes you can't avoid. I've given you an example of a few EEGs I've recorded at my hospital, and some of them are beautiful in terms of technical, and you don't have those many confounding factors. Sometimes they're difficult. Patient might be sweating, and you'll be developing, let's say, sweat artifacts. So the technician has to be wary of that and be able to try to eliminate any non-physiological confounding issues in your EEG.
Okay. Another question from Dr. Al-Hijji. Have you seen any brain death patients with the normal EEG?
A normal EEG? No.
Mm-hmm.
No. You could be having cerebral activity, just so they know. So there is a slide. Let me see if I've kept it. So there have been reports. Where is it? Hold on. There have been reports, as I said, of ongoing EEG activity despite clinical brain death. And the most reports are of alpha coma, theta coma, and what do you call it? Spindle coma. As I said, these are because of underlying subcortical structures. But none of these case reports have ever shown to have a recovery of this patient in terms of any recovery of spontaneous activity of breathing or brainstem reflexes or waking up, right? Recovery from coma. So technically, when you have a clinical diagnosis, even if the EEG is not of a brain death, you need to rely on your clinical assessment. I've never seen any case report of a normal EEG, but you could be having residual cerebral activity of other abnormalities, other deep, poor prognostic comas.
Okay. The other question is the role of quantitative EEG in determining brain death.
Why would you need a quantitative EEG in determining brain death? Quantitative EEG is, I think, more helpful when you're trying to detect underlying seizures. But for brain death, you don't really need a quantitative EEG. You just, and you won't be able to use, let's say, single electrode or quantitative EEG because you have to follow a strict guideline protocol. So to my knowledge, there's no role for it. And I haven't seen any reports of people using it. Maybe I just, I haven't looked, it didn't come up into my search. If you're aware of anything, I would be happy to know about it. But to me, there's no role of it.
Yes, I think this is the role, yes. So the other one, how long would you stop sedation prior to EEG brain death evaluation and how it is different for the kids?
Oh, yeah. So I'm an adult neurologist. However, I did read these articles that I've presented. The guidelines have sections for pediatrics. Right. And there are a few changes. And unfortunately, I won't be able to answer the question about how is it different for kids. If there is anybody in the attendees who is a pediatric neurologist who could help me answer that question, I would be more than happy to get their input. But in terms of how long, again, the guidelines say is about 5 half-lives. Depends what's the sedation. Propofol is the fastest one to stop, right? And the most commonly used. However, there are cases and there are some centers who use phenobarb. Phenobarb has a very long half-life. It has about a 90-hour half-life. So you will wait about 3 days before having a complete elimination or doing a blood level to really be sure that there's nothing left of it. Sorry, I'm saying, yeah, phenobarb. Anything left of it before saying, okay, now the patient is off sedation, off medication that could obscure my examination or EEG, and now we should proceed. All right.
Another question from Nasser Zahani. I think role of EEG in persistent vegetative states.
The role of EEG in persistent vegetative state would be more about qualifying underlying coma, right? To see what type of coma they have. The coma itself would tell you if it's a poor prognosticating coma or not. The other thing is trying to sometimes continuous EEG monitoring in persistent vegetative state would help you identify if the patient is having underlying ongoing subclinical seizures or non-convulsive status. That would be a factor why the patient is not waking up in a persistent so-called vegetative state. But if you have a well-established diagnosis and underlying etiology, then you don't, and somebody has a long history, like being in the persistent vegetative state for a long time, you don't need EEG, I think, to further diagnose that situation. I hope I answered the question.
Yeah, I think this is the question.
All right.
No more question.
So being here in Saudi Arabia, I just recently also got to know that EEG over here is not mandatory. Again, we don't for diagnosing brain death. However, it's mandatory if your patient is a candidate for organ donation. We've had a case in our facility again of somebody who was a candidate who was interested in organ donation, was candidate for organ donation. They had clear-cut diagnosis of brain death, but we did EEG just to fulfill the requirement of the government for organ donation. And as I said, I think there's a lot of move towards using EEG if needed and only in need, but not really as a mandatory requirement for declaration of brain death.
Here, question from Dundi. Do we need more than one expert to determine brain death officially?
It all depends on where you are from and what your country or region requires. But according to the EEG Guidelines and the Brain Death Declaration Project, you don't need more than one expert. A lot of the ICU intensivists would like our input just to make sure that they've performed they can do it on their own, but they make sure that we've performed the brainstem reflexes completely and fully, and it's accurately documented that there is no residual activity. But most of the guidelines don't require two physicians. One physician is enough. And where I was trained, there were a lot of situations where they never called a neurologist to declare brain death. The ICU, the intensivist can do the full assessment on their own. All right.
I think no. I think it's all points now have been clarified.
Sorry.
All points have been clarified.
Yes. So I don't know what the experience of other physicians of you, Dr. Jumana or Dr. Amal, has been around this topic in your facilities, in your hospitals. Has it been any different?
No, same.
Okay.
I think we're just.
So again, for attendees, please, if you have any question, you place it in the Q&A section, please.
All right, I guess I've answered most of the questions, or I hope I've answered most of the questions. Dr. Amir, would you like to add anything?
Well, I think you have covered everything, but I don't know why it's so hard to have a universal guideline, It's just the project that you have talked about, World Brain Death.
Yeah, well, they did mention, right, when they're doing the recommendation, we have to keep in mind the different country requirements and the society, cultural, and religious backgrounds. They actually had a very nice table. Was it in this article or a different article? In one of the articles, I believe it's in the World Brain Death article, project article, where they looked into the different even religious beliefs and who were more acceptable to the brain death criteria or declaration of death by neurological criteria, and who were least likely to accept brain death as a measurement of death. And some just based on religious belief, they were like, no, this is not enough to declare somebody as dead as long. So then, that sometimes limits also and pushes some countries, some regions, some physicians to perform ancillary tests.
Yeah, I think this is the case. Okay, Dr. Jumana, if we have more questions or just to conclude.
No more question. The presentation was beautiful and valuable.
Thank you. All right, then have a great night.